Coffee with Coker is a healthcare business podcast from the Coker Group that focuses on solutions to help healthcare organizations effectively navigate the changing healthcare industry landscape. Welcome back. Michele Madison is joining us, and she's been on the podcast a couple times, but thanks, Michele, for joining us for the discussion today.
Absolutely. Thanks for having me.
What we're talking about today is actually kind of, as we record this, we're a year out of the initial spread or development of COVID-19. And what we thought would be interesting is to talk about a discussion around some of the general pain points. Michele works with a lot of hospitals, and as do we, and in many cases work alongside each other, our firms. Obviously, there's been much to develop in the last year with everything. And so again, we thought it'd be helpful to talk through some of the pain points, some of the observations of what, hospitals and executives and groups, frankly, are dealing with most acutely, and kind of looking forward what some of the expectations might be. But and before we dive into the conversation, I do just want to remind everybody, you can find all of our podcasts via our website. If you subscribe to us, you'll get alerted. So we have these kind of discussions regularly. There's a lot of good material there via the website at cokergroup.com, and you can follow us on all the social media and stay up to speed on these types of discussions. But with that, Michele, I thought, there's a few things obviously we can talk about as it relates to hospital pain points. What do you think as far as the some of the top, one, two, or handful of things that you're working through or helping to navigate some of your clients with?
On the hospital side, a lot of it's really focused on the maintaining of the physician relationships. And now that we know what a pandemic can do to a hospital organization, focusing resources on service lines that can use telemedicine, remote patient monitoring, a lot of focus on looking at that value-based entity, because now we have a new Stark exception. There are anti-kickback safe harbors that are going to provide more flexibility for hospitals to be able to provide payment to physicians for achieving outcome measures that really impact care and reduce cost. So there's a lot of momentum towards how do we bring together the full continuum of care of physicians in partnership with the hospital, and then go out to the payers and negotiate these risk-based contracts where we're actually doing care coordination to reduce costs and get a share of that savings based on our quality outcomes. So that change in dynamic of focused on moving away from fee-for-service to value-based, we've been hearing about it for years. And now it's really pushing it because of the new Stark and anti-kickback changes. It's at front of mind for everybody. And so it's a lot of education about what's involved. It's not as easy as flipping a switch. And then moving forward from there, how do we put the infrastructure in place to really make a difference? And what were our measures before, and how are we performing before? Because that impacts your efficiencies going forward. So that's one big area. The other area has really focused on the delivery of care in the hospital setting and the outpatient hospital setting. And this because more and more patients didn't want to come into the hospital during the pandemic for that fear of, I'm going to get COVID when I go to the hospital. And so we had to be flexible to figure out, well, these people still need care. Otherwise, we're going to have a critical crisis on the healthcare side when they do come to the hospital. They haven't had preventative care. They haven't had testing for months. Now they're really going to be sick. And that's just going to inflate the cost of healthcare. So looking from a hospital standpoint strategically, how do we focus more on ambulatory surgical centers, outpatient delivery of services that can be done in a site of service where the intensive care for COVID patients and other patients during any kind of pandemic can be delivered on an inpatient side, but we can really expand that outpatient delivery. Some of that's home health, some of it's remote patient monitoring, some of it is literally home visits again, which is so unique. But those are the areas that I've really seen a lot of development, a lot of discussion over the last several weeks.
Yeah, that's really helpful. And I want to actually dive in. You mentioned a couple things. I do want to talk about telehealth and remote patient monitoring. Before we do that, though, one of the things that's been getting a lot of attention that we've been getting questions a lot about from our hospital clients and physician practice clients is what you reference in regards to Stark and anti-kickback updates, and then how that ties into some of the changes that went into effect January 1 as it relates to E&M coding. Are you seeing a lot of questions there as far as being ready or needing education, like you said?
I think there's a huge need for education. This is something where we knew it was coming, but I don't think anybody could fully address the impact because we thought, all right, what's happening, just in case anybody's on the line that doesn't realize it, in 2021, the E&M codes, if you are paying your physicians based on work relative value units, WRVUs, and their compensation, and they're having a lot of E&M codes in their practice that they bill out, the weight of that RVU for that E&M code went up. And so the problem is it went up more than the reimbursement went up. So there's no offset. So if I'm a hospital and I'm paying my physicians on an RVU basis, starting January 1, if my contract said, I'm going to weight your RVUs based upon the current year's measurements from CMS, I'm now having an inflated RVU productivity number for my doctor without the reimbursement to offset the increase I'm paying the physician. And all the surveys that we use to look at physician compensation are based on the old measures. So it's going to look like the physicians are being potentially overpaid for services with that inflation of RVUs because now you're paying them more. And so initially, we were all thinking, well, we'll look at it for the first year, see how much of a deal it is. When we started looking at it at the end of January and February for some of the hospitals, we immediately had to put the brakes on and say, forget it. We've got to use 2021's weights because the contract and the compensation is based on a prior year's RVU weights, and we're going to lose too much money on the practice. And from a commercial reasonableness standpoint, that was unacceptable. We took two approaches. One was, let's audit it every month and see where we are. And I have some facilities where their docs do more procedure-based than E&M. And so we're okay leaving them because the procedures, and honestly, some of those went down on the weights, versus some that have huge primary care practices where we said, all right, we're going to amend the contract to only do the weights on 2020 until we can get our hands around potentially adjusting all the contracts to ensure it's commercially reasonable and fair market value. So that's been a new dynamic for this year, that although we should have been ready for it because we clearly knew it was coming, I don't think any of us really anticipated that impact in time. Maybe we were focused on COVID.
Yeah.
But now we're really seeing it, especially as we go into the end of the first quarter for 2021. Because some of my facilities that I work with, they look at it quarterly. So we're running the reports now, and it's an eye opener for a lot of our practices.
Well, that's funny. I mean, because we experience the same thing when we're looking at, say, we're advising a client on fair market value, commercially reasonableness, and even opining on comp structures. That's a huge adjustment that has to be made, and the forward-looking capability on that is always a challenge. And we have clients, they look at it quarterly, some run it monthly, others may not look at it very often at all. And let's face it, different hospitals and health systems have varying degrees of proficiency around their E&M coding anyway. So sometimes that's already a challenge and a little bit behind the eight ball when it came to these updates. Now, I think it's interesting that we've seen a couple of different things as well, as far as how prepared they were. And then, like you said, then having to even go in and adjust some of the things they were already preparing for leading into January. Your comment about these surveys is really interesting, because not only do we have the kind of old data, the old survey data or historical survey data that has to be adjusted for just 2021 changes, but when the new surveys are released this year that have incorporated 2020 data, we're going to see, or we're expecting to see, some pretty significant outliers and variations that normally we wouldn't see, simply because 2020 was such a unique year for both productivity and income. So I think it'll be very interesting going forward, even looking into beyond 21, what some of those surveys are going to ultimately tell us and how we're ultimately going to have to adjust for that. Are you even thinking about that yet, or is it kind of just still too early to tell?
No, I am thinking about it. I hadn't thought as much, but it's a great point that not only do we have this increase in 2021 that's not going to be reflected in 2020, and then we had the pandemic on top of it. I mean, it's like a tsunami together is a problem. So I think the survey data for 2020 is going to be difficult to use when we're setting comp going forward with these change in the weights, because a lot of the physicians and the hospital employed docs had to shut down their practices for at least some period of time.
Hmm.
We did see a lot of patients come back. I mean, if we shut down, let's say March 13th, and we tried to reopen pretty quickly, at least part-time, and doing telemedicine visits, especially because telemedicine visits were getting paid as if they were in person. If you had the right infrastructure and your patients were on board, we saw some of that regain in April time period. And it wasn't really until the summertime, like the physicians with the ASCs and the ones that needed to see the patients in the office more, that we started to regain it to about the 80th percentile
Yeah.
where they were before. So there is that hiccup from March until, for some practices, mid to late summer. And then there are some practices that I don't know that they ever got back on their feet totally. I don't know
Hmm.
that they ever recovered totally. So we will absolutely, you're right, the survey data is going to be challenging for 2020.
Yeah, we saw the same trends from, some did okay, some just for whatever reason, like you said, maybe there were telehealth capabilities, maybe it was their region or their particular specialty. They were able to at least recover fairly quickly. Some, it's just really, like you said, never seemed to fully recover, or maybe even still struggling. I think the other thing, or probably more the private practice side. I don't know that this would be something that would trickle down to the physicians on the hospital employment side, but with the PPP money, a lot of practices got that. And we've heard all kinds of different stories as far as what they did with it, how they distributed it. Was it income? Was it, invested in, supporting low cash flow and kind of a stabilization measure as it was meant to be. So again, that'll be something that it's going to just take time to tell. But what are your thoughts as far as looking again the last year? How does this tie in what you're seeing with hospitals and physicians actually doing deals, or have you seen, I guess, both from a perspective of the volume, meaning has there been continued deals, more deals, less, people hesitant, and then also the nature of those transactions? Are they similar to what they were before 2020? Are they kind of looking at new alternatives, new structures, new terms, and things like that? What are you seeing there?
So the hospitals have continued to look for the recruitment of the physicians. I think one of the big things that came out is when you have a hole in a specialty or you don't have a deep bench in a specialty like infectious disease. I saw a lot of recruitment around that. And now I see a lot of telehealth contracts around infectious disease, believe it or not, because there just aren't enough for everybody to have one or two. So I've seen the recruitment continue. I have seen some hospitals trying to consolidate their practices in a manner where, okay, we need this outpatient ambulatory service. So should we look at doing a joint venture on an ASC with a physician group because we couldn't get the patients to come in the hospital to do surgery? So is there an innovative model related to ASCs? And I've seen a big focus on hospitals looking at that outpatient ASC kind of model and bringing the physicians in to tie in on the physician side. Unbelievable growth in, we want to create a management services agreement. We want to consolidate a bunch of practices together. We want to reduce our overhead with that management services company. And then we are willing to look long term at private equity or somebody else coming in and buying that management company. Tons of talk about how do we as physicians become more efficient, because the biggest thing they saw when they were having to transition from, I see my patients every day in my office with all my staff and my MAs and PAs and billing and administrative staff, to they're not here because their kids' school is closed and I'm still paying. And granted, PPP did help. I'm still paying salaries, trying to have those people work remotely. I can't see the patients in the office except on limited time periods, and I'm having to do telehealth. So why do I have this big overhead infrastructure? And how do I move that overhead infrastructure and combine it into a management services agreement where I reduce my cost and I share that cost with 5 or 6 other practices in the same specialty that had the same issue? Because you need the same kind of staffing. You need administration, you need billing, you need MAs and PAs. And you could use that in one management company for maybe 6 different similar specialties. And those practices have been talking about how do we consolidate from that standpoint. And then, as I mentioned earlier, there's that focus on the value-based entity arrangements. And so hospitals and large physician practices looking at a clinically integrated network, that's back on the table as well.
Yeah. You mentioned considering private equity as an alternative, and that's definitely something we've seen. I don't know if it's correlated with COVID. I don't necessarily think it is. The private equity trend was here long before that. But I will say we are just getting more and more questions and frankly doing more and more work around private equity related deals. And when I say private equity, I'm kind of using that very, very broadly to really mean these include all for-profit entities that are now in the market of buying physician practices. Where do you see that currently and that trend? And have you seen an increase? Are you seeing more of it? And what are your thoughts as far as looking ahead and whether it's considering private equity as an alternative or if it's, there's many different models from these for-profit operators. What are your thoughts there?
I'm seeing more. I know it was there before, and I saw it every so often. But now, if you look at dermatology or GI or certain kinds of ophthalmology practices, I'm just seeing more of it. Cardiology, I'm seeing orthopedics, I'm just seeing more of it. And I personally, if you look at the federal dollars that went into healthcare during COVID, the infrastructure that was supported, if I'm a private equity investor, I'm thinking, well, that's an industry that is, what's our term we used to use years ago, too big to fail when we had the recession.
Right.
So,
recession proof.
Yeah. So the federal dollars went into that industry. If I'm a private equity guy, I know they're going to have funds, if they use them correctly, to stay viable and to be able to sustain. So I think, and this is my personal opinion, I think that has contributed a little bit to the increase that I've seen recently, at least in this first quarter of 2021. And the other part are our docs who, honestly, some of them are just tired. That was a hard year and it's not over. And dealing with the day-to-day operations of a practice and dealing with the overhead and the HR side of it, and knowing that you could take some money out of the practice now and maybe make your lifestyle a little bit easier, still working, obviously, and having the ability to have ownership in a management company that you get to take a second bite out of the apple later is a nice thing to have on the horizon when you've just been through everything you've been through this past year. So I think the dynamics are right. And that's why I think I'm seeing it more right now.
Yeah, I think you hit the nail on the head. There was a time where the majority of the questions or the interest in pursuing these types of deals from the physician, from the seller perspective, was more economics. But I think the other factors, the non-economic stuff that you mentioned, taking risk off the table, just some more stability, removing hassle or challenges that come with running your own practice. Yeah, I guess they've become a little bit more of a priority. Obviously, the economics that have to be there to make it all work. But I know, and you and I have even spoken on this and presented on it before. But I've heard you make the point around when a potential seller is considering such a transaction, going beyond the economics. Maybe comment on that if you don't mind, as far as some of the other things besides just seeing the dollar signs of a term sheet. But what are some of the other things they should keep in mind and consider when they're looking at these opportunities?
So this is when I feel like I turn into a counselor to my docs, because I really wanted to focus on the culture change, because that dollar amount looks really nice, but you are typically a pretty driven person as a physician. So I know when I'm in my shoes, I'm very type A. Losing the autonomy over a practice that I have built or that my partners and I have built together, I think is a very different dynamic. And so you really have to look at the culture. I think you've got to interview the investors more than once or twice. Anybody can, show you what they think you want to hear. You really need to talk to the people that they work with today to see, how did it change for you? How did the culture change? What was the day-to-day interaction after the deal went through? Some of them are super successful. They are the right fit. They're the right culture. They're the right people. They're the right efficiencies. Sometimes you'll have somebody who comes in and wants to change everything because they feel like they know it better. And if I'm a doc who just built this practice for 25 years, I really have to make sure I'm willing to do that, because the dissatisfaction, it's not like you're going to stop working. You're going to continue to work when the private equity guys buy an investment interest, and you may now have a joint venture interest in a management company. Your partnership continues with them post close. You're not exiting. So you've got to make sure that this is the right fit for you and that it's the right thing for your patients. All of the docs that I work with, their patients are their first priority, patients and their employees. And when they look at how can I deliver care to my patient, making sure that they can continue to meet the access needs in that community and grow their practice while serving the people that they go to church with and see at the grocery store, they need to make sure that they're going to have that autonomy to still be able to control that at a local level, or at least have a partner who's going to be the right partner to make that happen in the future. So the culture part is the number one priority. The money comes second in my mind. And it's really something you've got to talk about as a group, because I have some groups that have 20 something doctors and not everybody sees it the same way. So making sure everybody's on board before you just go pull the trigger.
That's well said. I mean, the you hit the nail on the head as far as culture goes, and I think what it boils down to, when we're working through these, is you have to be willing to ask the tough questions of yourself. Not just, I would agree, go and interview the buyers, interview and talk with some of the other groups or physicians that they've done deals with before, and kind of the standard reference check stuff, but a very deep dive. But by the same token, ask yourself, or be willing to ask yourself, the hard questions around culture. Is this something that I'm okay with, that this is going to work well with me after building my practice for 25 years, or all the effort that went into it, and my staff, is my patients, like you said, is this going to be something that I can step aside or work under? And that can be a gut check sometimes. And I agree on the for the larger groups, or frankly any size where there's more than just a handful of close partners. Getting everybody on the same page is always a challenge, because let's face it, they're maybe at different stages of their career, different kind of needs and preferences, different personalities, obviously. So those are all really big points of consideration. I wanted to come back and bring it full circle. Earlier you mentioned, and we've kind of talked around telehealth and remote patient monitoring. Obviously, telehealth is something that we've talked a ton about. It was here before COVID, but obviously just exploded in response to COVID, and still very, very high numbers, or good high volume around telehealth, virtual care, et cetera, et cetera. But the rise of remote patient monitoring is something that I've seen grow almost just as fast. And we were talking about it a little bit pre-COVID, but in the midst of summer 2020, I started seeing more and more come online, and now I see, literally dozens of companies out there that all they do is RPM, or existing technology platforms that have very quickly expanded into that space. What are your thoughts there?
So I think our remote patient monitoring is going to expand unbelievably. So when we saw telehealth take off in the COVID pandemic, because we had to have access to our providers and we all kind of adjusted to that telehealth concept of medical visits, then the remote patient monitoring was hand in hand with that, because now I can get my blood pressure and it can Bluetooth over, and it can get to my physician practice, or I could take my weight on my Bluetooth scale, which I would never do. But all of those different items. And then the cardiac monitoring that can be done at home, and all the monitoring that can be done with diabetic patients. So having the ability to take a device and bring it to the home and allow that data to come back is unbelievably efficient. It cuts down on cost. So when we talked about the value-based arrangements, we're trying to reduce cost and provide quality outcomes. So if I can use remote patient monitoring to watch my patient and know when something's happening, and I can track and trend them daily, and I can see it on a graph. If I have a 20-pound spike because I'm retaining water, I'm a congestive heart failure patient, that's going to trigger my doc to call me that day and say, get in here. that's going to prevent me from having to go in every week for testing. I'm going to have this monitor at home that'll tell you. And so as a result of doing that, I think that remote patient monitoring is going to make it more efficient. Physicians and hospitals can use it to reduce cost. We can improve the quality of outcomes, and that drives right into value-based arrangements and care coordination. The other thing is during the pandemic, they loosened the supervision rules about how physicians can supervise and mid-levels can be involved. So while we have a shortage of physicians, we are going to have more mid-levels involved in interpreting that data coming over and ordering more tests based upon the data. And that's going to make timely interactions with patients based upon the data coming from the remote patient monitoring. The challenge I see with remote patient monitoring, I think reimbursement will pick up just as telehealth has picked up over time. I think the challenge is going to be making sure that the data comes across and can be used by the physician. I have a lot of docs who say, I'm overloaded with data. I open my medical record and now my patient's got remote patient monitoring. I've got all this data feed coming in and I don't want to miss something. And I'm worried about liability if I miss it. I need it to be meaningful and actionable in a manner in my EHR system. So I think remote patient monitoring and the EHR systems have great opportunity to work together to get the critical data points in front of the physician versus what one of my docs said. He's like, it's a bunch of noise and I got to dig into it. We need to have a system that pulls it out and makes it very easy so the doc can have an intervention with the patient.
That's a great point because we saw that, like you alluded to, when EHRs really first came online and became the norm. That was something that I think that was kind of the second wave of optimization around EHR was, hey, how do I actually use this so it's a positive benefit as opposed to an added hassle or a new hassle. And I think the RPM thing is definitely in that same vein, and as far as optimizing the analytical capabilities, what you're doing with the data, making it actionable, but also making it where it's not requiring even more time on the provider side. Also, the security side of it, I think, is something that is never going to go away. It's security is always an ongoing need and challenge sometimes. But I also think the technology, I think we all know, is there. I think what we have not fully achieved yet is consistency around reliability. And so when you have something, for instance, a device, I mean, let's face it, we have all kinds of devices around us already, and have always running into whatever challenges that may come with that. So it's not that the technology isn't capable, it's just not always exactly reliable. So I think there's that balance between monitoring data versus monitoring the patient truly, as a provider wants to do, is going to still be something that we kind of learn and navigate.
Yeah, I agree.
Well, anything else? I know we covered a lot here. Any kind of final thoughts as far as looking ahead through the rest of 2021 and what some of you're helping your clients look out for or plan for?
Yeah, I think it's going to be a year of consolidation, whether that's purchasing, merging. I think it's going to be a lot of integrating care to figure out how to reduce cost. And it'll be testing ourselves on, can we achieve that quality cost so that we can go to the payers later and negotiate value-based arrangements. Yeah. And I think the other part will be coming out of this pandemic, we've learned a lot. There are a lot of new practices that we can implement that help our patients get access to care during troubled times. And then the transportation issue that always impacts patients. I think we're going to be able to tackle that better now with these changes in the anti-kickback statute and the safe harbor for local transportation. I see that as being a great policy change that's going to impact rural healthcare. So that's kind of what I see for 2021.
That's very helpful. I appreciate your insight, and it will be interesting to continue see how we navigate through this, and I'm sure we'll continue this discussion throughout the rest of the year as we learn more. But in the meantime, thanks again for joining us, and we look forward to continuing the discussion in the near future.
Thanks for having me.
We hope you enjoyed that episode of Coffee with Coker, and we thank you for listening. We want to encourage all of our listeners to participate and contribute in the podcast. So if you have any questions on any of the things we discussed in this episode, any of the topics that were presented, please feel free to ask us. Also, we welcome your feedback and suggestions. If you have any ideas related to the material we discussed in this episode, or in any episode, please let us know and we'll make sure to incorporate it. And if you have ideas for topics you'd like to hear more information about in future episodes, please send those suggestions to us. We would love to hear them and we'd love to incorporate them into our future episodes. You can find us online and on social media. Start with our website, and specifically the podcast is coffeewithcoker.com. You can also find that through the main Coker website at cokergroup.com. You can also find us on social media, Twitter at Coker Group, and then on LinkedIn, you can search for Coker Group and find our page and the page for some of our team members as well there. So you can find us and reach out to us a number of places. And then if you want to contact us directly, one of the best ways to do that, email feedback@cokergroup.com. That's feedback@cokergroup.com. And again, we'd love to get your feedback, and we'd love to encourage everyone to subscribe to the podcast so that you can be notified when future episodes are released. We look forward to the next episode, and we look forward to getting your suggestions and feedback on this episode. Thanks for listening, and we look forward to speaking with you again on future episodes.